Before we jump into this episode, I want to remind you that while Caitlin and Sophia are dietitians, we're not your dietitian. This means the information shared in the Food Freedom Fertility podcast is intended to entertain, educate, and inform. It is not a substitute for medical care. This information is not intended to diagnose, manage, or treat disease. Always consult with your doctor before making any changes.
Okay, so welcome to Connection Corner, where Sophia and I laugh our way through reading your comments and reviews. This one comes from Mao P7C, and when I first read this, I thought we were going to be reading about ADD, but she just means add. So let's read this review.
I thought that too. Mao P7C says, love this podcast. I am not even halfway through all the episodes, but I am loving it. I think what I like the most is the delivery that Caitlin and Sophia have. Some other podcasts / social media posts I've seen or heard giving similar information just tell you what you shouldn't be doing, and they leave you feeling guilty and full of anxiety about your health and your fertility journey. These two focus more on what to add to your life and keep it realistic. After listening to them, I feel hopeful and excited about my journey rather than anxious and scared. They give you suggestions that are easy to add in or change that won't turn your whole life upside down. Great information here, and the way they put it out there is so helpful. Oh, Mao P7C, you are so kind. And this is exactly what we strive to do. Yes. I completely agree with you where a lot of experts or people that tout themselves as experts are pretty much just out there giving you a whole list of what they don't do and what you shouldn't do. And it makes life seem really unlivable. Like, what are you supposed to do if all you've ever done to cook is use spray pan and a Teflon pan? What are you going to do if you don't know how to cook without that? We don't want to tell you what not to do. We want to tell you what to do.
And there's if you're only hearing what not to do, people conflict on that. So you could basically have nothing left after you listen to everyone talking about what not to do.
And we don't want that for you. We want you to have a realistic and helpful journey, and it sounds like that's what you're receiving from us. So thank you for your wonderful review. Welcome to another episode of Food, Freedom, and Fertility. We are your hosts, Sophia, Pavia, and Caitlin Johnson, both registered dietitian nutritionists, both specializing in women's health and fertility. I, Sophia, the specialist in progesterone production, the 2-week wait, getting pregnant, staying pregnant, and continuing through a healthy pregnancy. Kaysen, oh my God, help me. Caitlin.
Sophia's still nursing her coffee this morning.
Oh my God.
I treat mostly PCOS.
Mine. Oh, yeah, Caitlin treats
we have Dr.
PCOS.
Gary, where we have
hello, everyone.
The reproductive endocrinologist.
Who hopefully treats speech impediments, because I seem to have developed one.
Well, the funny part is he's in Hawaii. It's so much earlier for him.
And I forgot my coffee.
Oh, no. Oh gosh. Do you want to go get it?
That's okay.
Oh, God bless you.
We're gonna power through it.
We're gonna power through.
So, oh boy, this is gonna be such a good episode. I can already tell. We recorded like liquid audio gold a few weeks ago with Dr. Gary. Only the version that recorded had some garbly, very difficult to understand. So you get a bonus episode with Dr. Gary. He is gifting us
I appreciate it.
Another hour of his time. But we're going to kind of go through the same things that we went through last time because what he said, we all need to hear. So we're going to kick it off today with something that's very prevalent, at least in my DM box and even clients that I'm seeing personally in my course and really, frankly, if you're alive and have a phone or watch the news, you've heard about Ozempic, Wegovy, you've heard about Mounjaro, you've heard about, we call them semaglutide or tirzepatide. These are medications that people are trying to get their hands on to help manage weight and a host of other things. Every day I feel like there's a new message that's coming from somebody saying the FDA just approved it for this. Most recently, management of heart disease and heart disease risk. So my question revolves around the idea of safety for somebody who is being prescribed this or who personally wants to seek out these medications in the context of trying to get pregnant soon, or perhaps within the scope of you need to lose weight before you can access this treatment, or to help improve ovulation dysfunction. Give us the details, Dr. Gary, from your perspective.
All right. Well, thank you again for having me on. A little bit of a side story. We used to have this. Well, I guess we not used to have it, but there was a very prevalent diagnosis called luteal phase insufficiency. And the way we used to diagnose it is we used to biopsy the endometrium at different days in the luteal phase, and then we would compare the day of the luteal phase based on when progesterone would rise or the LH would go up to what the pathology is. And the way we used to diagnose it is to see if there was a discrepancy between the day of the biopsy and when the progesterone would rise. And that was the first publication in Fertility and Sterility, which is our journal. And we used to diagnose it for 50 years that way. And then we did another study. And what we saw with the people looking at the biopsies, there was basically a discrepancy between them when we would give them the samples at different days. And so we kind of went away from diagnosing it that way. So I'm hoping that the second podcast is not going to be like that. We come up with the same conclusions.
Yeah. Wow. And that's so interesting. The luteal phase deficiency testing that way. I mean, that's so invasive. That's so painful and so much risk. Boy, howdy.
And that was a standard test, and that's how we would diagnose luteal phase insufficiency. So every person with recurrent miscarriages would undergo this invasive testing for, I think around 2008-9, we stopped diagnosing it that way. But anyways, so
Wow.
your question was about GLP-1 agonists, and it's basically a class of medications that help blood sugar control in people with type 2 diabetes. And some of these medications are now used to treat obesity. And there are some other names for these medications like glucagon-like peptide agonist, GLP-1 receptor agonist, etc. Primarily what they do is help the patients feel fuller. And so there's a decrease in the amount of consumption of food. And so they tend to be fairly effective for that. The Everyone has to kind of obviously weigh the risks and benefits of starting this medication. Primarily at FertilityCloud, we don't prescribe them because we feel like they have to be monitored. There's certainly a lot of side effects associated with them. It's a newer medication. The manufacturer, because they have not done trials on women who are trying to get pregnant or are pregnant, recommend a 2-month interval between stopping the medication and getting pregnant, because we have at this point absolutely no data of what happens in pregnancy on these medications. There are some people using it off-label in pregnancy for diabetes control in women with really hard to control diabetes, but that's a separate issue entirely outside of the people who need to lose weight and people who are overweight for other reasons. So I guess the long-winded answer to your question is that I think it's a tool in an armamentarium of, at this point, for women or for patients who are trying to lose weight and are unsuccessful with lifestyle interventions, dietary changes, exercise. We don't use them at FertilityCloud as the first line, or we don't prescribe them at all at this point, simply because we think it is a class of medications that requires a lot of scrutiny and a lot of specific, specialized management. Unfortunately, we do see a lot of internet physicians and physicians who are not trained specifically to prescribing them because they can be somewhat lucrative as well.
Yeah. Well, thank you very much for that answer. When I hear the feedback of patients I know who have used these medications, what I hear a lot of good for better, for worse. Probably on the side of the for better, I hear that it really cuts down the food noise, the obsessive thinking, the like, you're sitting at your desk and you think of a blueberry muffin and then you're like, no, I'm not going to eat blueberry muffins. I'm trying to watch my blood sugar. Enough with that. Okay, focusing on work, blueberry muffin. No, we're not eating blueberry muffins. Oh, but I want one. No, but we're not going to have one. And their mind is like constantly cycling in and out of thinking about food. And it's so distracting that they eventually cave in as their willpower diminishes and, the day gets tiring, difficult things happen, and they wind up eating things that are bad for their blood sugar, even though they were really trying to turn a new leaf today. I
Yeah, you're
hear
absolutely right.
that it's like
You're
a
absolutely
lot
right.
easier to say no to things because you're
Hmm.
just, you don't feel the craving physically the way that you would before. The thought of the blueberry muffin comes in, you can say, I'm not going to have that right now, I'm focusing on my work. And then the thought leaves and you move on with your day. And sort of the for worse side of things, I see patients that just really don't have much of an appetite. They're feeling sort of upset stomach, kind of queasy, just really ick, like kind of not like you have the stomach flu, but maybe like the day after the stomach flu, where you're not like sick in the bathroom anymore, but you just really don't want to eat very much. That's sort of how it's been described to me, that they're just really no appetite, which might sound like a good thing for somebody that has, 80 pounds to lose and has tried everything. But it's not really that great of a thing when we think about the fact that we need to actually be nourishing your fertility. So it's
Hmm.
great that you're not obsessing about muffins and candies and things like that. But I don't know about you, when I'm feeling a queasy tummy, kale and eggs is not really the first thing that I'm reaching for. And so I see women, they do lose weight, but often it's because they're kind of like sipping a diet ginger ale and like maybe munching a couple peanut butter crackers throughout the day because they're just not feeling very good. And we see weight loss, but we're not nourishing fertility really at all along the way.
Yes, I agree with you. The underlying mechanisms of action of this medication is blocking glucagon secretion, insulin release mechanisms, but primarily slowing stomach emptying, so it
Mm-hmm.
decreases gastric mobility, and then increasing satiety. So after eating a much smaller amount of food, patients feel fuller, and also it takes a lot longer for food to transit after they finish a meal. So from that perspective, it is effective. But yes, you're absolutely right. Then um, the appropriate nutritional choices may be affected by that because then people may default to things they want or like to eat or want to eat, and the effects of the medication may potentially counteract
Mm-hmm.
poor nutritional choices while they're on
Yes.
the medication. So, and the other downside is once the medications are stopped. So, for example, if women are or patients are using it to lose weight in preparation for pregnancy, they stop 2 months before, as the manufacturer recommends. We tend to see a significant rebound in the amount of weight
Mm-hmm.
gained back. So it's not, it certainly is an option to lose weight for people who really are struggling, but in my opinion, it certainly should not be the first line intervention.
Mm-hmm.
And I agree with you. The optimal nutritional choices.
Changing your habits and your approach with food. Exactly. And that's another thing too, is that, yeah, I see people that really, they have not changed their lifestyle whatsoever. They're not
Mm-hmm.
moving more, they're not eating more fiber and protein and making better choices for their fertility when it comes to food. The weight is just coming off because they simply don't feel like eating. And then
Mm-hmm.
the rebound effect is really big, just like you said, coming off the medication and then wanting to eat everything in sight because your body has essentially just been starving and you haven't actually done the internal work of what to
Mm-hmm.
do with all this food noise and cravings and things like that, because that really is, I mean, I don't want to call it like a mental illness that you are thinking about food so much, but it really is, let's call it an unhelpful mental pattern that there are legitimate psychological treatments for, and there's a lot that you can learn and do to change your relationship with food and with your own appetite and have a more positive, not codependent, symbiotic relationship with your own body, your mind and your body together. And I see that these medications kind of help people. It's almost like a leapfrog, they can put the cart before the horse. But I understand the desire to use them as well, because, if you're 36 and you're trying to have a baby and your doctor says you need to lose 60 pounds before I can even give you Clomid or Letrozole or whatever, you're like, okay, well, I don't really have the next 5 years of my life to like go to binge eating therapy and figure out, why and how I'm using food to cope with the traumas of my past and blah, 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 blah. I need to lose weight today so I can get pregnant tomorrow because my fertility window is closing.
Hmm. Yeah, I mean, you're absolutely right. It's can be quick. It can be a lot easier than modifying your behavior or lifestyle. But I think what I'm going to say is going to potentially be somewhat controversial. Um, no,
We love that here.
the way that the modern, um, I don't want to say food system, but the way that everything is set up this way, and a lot of the processed foods, a lot of the things we consume in the Western world is addictive, and we've
Oh,
seen
amen.
the studies. It is as addictive as certain drugs, and potentially more so, and it's everywhere, and it's encouraged, it's advertised, and so yes, absolutely. People use food and addictive food and sugar and processed sugar to cope with a lot of things, whether it's stress or past trauma or anything, and it works, just like alcohol would work or
Yeah,
just like drugs would work. But unfortunately, it also has a very significant side effect,
it does.
just like alcohol or drugs.
Well, I
And
would argue not just like alcohol and
well,
drugs.
yeah, yeah, yes,
Nobody ever like
I'm.
crashed their car, like got
Mhm.
evicted because of too many Hershey Kisses, like
But the number one killer is heart disease. 40, or was it 40 to 45% of the US population is now obese. So it does have
it
significant
has
side effects.
significant risk.
Yeah,
Oh, yeah, no
absolutely.
argument there.
Yeah, I mean, maybe not immediate effect like drugs and alcohol. Yeah, you're absolutely right. But within it certainly does have consequences. And so I think that, we can change things on an individual level, but I think at this point we have to have real systemic changes of how our food's manufactured, advertised to us, and also um, the nutritional pyramid. It needs to be, I think, revised significantly.
Well,
And
supposedly it was, right? And now it's My
mhm,
Plate, which
mhm,
is the same thing, just repackaged.
yeah, absolutely. So we have a lot of work. We have a lot of work ahead of us to improve how we eat and what our relationship with food and what food is in general. In terms of, we have to, consume food for energy, for health, versus for,
Purely enjoyment. Have
yeah,
enjoyment as
yeah,
just one of the features of why we're eating
absolutely.
instead of the main feature. And that is so much of what Caitlin and I are working to do on this podcast is like, we obviously eat for enjoyment. I am
Hmm.
about to go make a cherry pie after this, or these little cherry hand pies for my husband who goes out and works in the desert and
Hmm.
has extreme, these guys he works with, they are extremely stressful training circumstances, really hard hours. And sometimes it's like you're up really late and then you're up really early. And so then you're like, oh, but Sophia made these hand pies and I could have my like big black coffee in one of these pies and like the day is going all right. And there,
Hmm.
this enjoyment of food is real and it's absolutely a part of living a meaningful life. I don't want any listener to think that enjoying food is the problem. That's not it. It's just that is one feature of why we're eating, and it can't be the only thought, the overwhelming thought when it comes to how we're eating. I like to kind of help people understand, think about what you want and then add what you need. You're hungry. What do you want? Do you want something cold, something hot? Do you want it to be salty, spicy, sweet? Do you want it to be creamy? Do you want it to be tangy? Like, what are you in the mood for? And let's say the thing that comes up, like, name a food that you think would be just totally abysmal for someone to eat for their fertility.
Lucky Charms.
Lucky Charms. Okay, you want to eat Lucky Charms. How can we do that in a way that's going to support your fertility? So I would say we're going to have a couple of scrambled eggs on the side of it. We're going to have some fiber. So whether that's going to be some kale mixed in or peppers, or there's going to be some fruit on the side of it. So we've got our protein, we got our fiber. And then we have a portion of Lucky Charms next to that. And we're going to eat our fiber first, our protein second, and then have our sugary carb, the Lucky Charms, once we've had a base in our stomach of the food that our body needs. So there's never a, no, you can never eat this food that you love ever again. We're going to pair it with food that works for your fertility so that you can still live your life while supporting your fertility. And we're going to work on portions of things that are appropriate, because if you're actually hungry, you're going to sit down and eat a much larger portion of Lucky Charms than you would if we fed your hunger, your body's physiological desire for nutrition, with quality food, and then had those on as a dessert. So that would be my fertility recommendation of how to actually eat Lucky Charms in a way that's not going to destroy you. But think of it as, what do I want? And then add in what you need, because we do need good nutrition in order to have a healthy pregnancy. And that is where weight loss starts really gumming up the works, especially as far as Caitlin and I are concerned, when we're foregoing nutritious food for the sake of trying to eat less to be thin.
Yeah, one of the things we mentioned last time is eating less is not necessarily the solution to weight loss, right?
So
It's eating properly and ensuring you're maintaining your nutrition. Because thin is not always the answer, specifically when it comes to fertility. It's
very true. I mean, how many times in your practice do you see it's the women that are underweight that are having harder time than a woman that maybe has an extra 20, 30 pounds on her? I mean, when we're talking about somebody that has an extra 80, 90, 100 pounds, yes, there we're having bigger issues. But being a little bit overweight, just in the data that I've seen, doesn't seem to have the same negative fertility effects as somebody that's 20, 30 pounds underweight. We're taking a break to talk about our sponsor, FertilityCloud. In working with hundreds of you ladies, we have noticed a problem that has come up. I know it's come up for me, Caitlin. It's come up for your clients as well. And that is not only finding a doctor who is going to know how to help you, but one that wants to. We have a lot of issues here, and sometimes getting a simple blood test or actually getting a medication or talking to someone who's actually an expert in fertility can not only take an insane amount of time, but it can feel like you're fighting your doctor.
Yeah, or you're playing like Russian roulette to get in front of somebody who actually cares. We are so excited to be partnering with FertilityCloud because they have a solution for all of these frustrations. Just last week, I had a client that needed right now care, and we couldn't get her in front of an OB. And she got a same-day appointment with FertilityCloud and spoke to a reproductive endocrinologist and had a prescription that she needed in her hand hours later. This is a solution that our industry desperately needs, and we are so excited to present to you.
So if you're in a remote area and you have to drive 4 hours to go see a doctor, or if you've been to multiple doctors and none of them seem to really listen or really care or want to take an approach that works for you, start up with My Fertility Cloud.
My Fertility Cloud has provided us a link, so check it out in the show notes. That will get you $25 off your first visit with one of their providers.
We're taking a quick break from this episode to talk about one of our sponsors, the Prenatal Nutrition Library.
We love the Prenatal Nutrition Library. It's a searchable database and app, which means you have answers within seconds and peace of mind that what you're eating during pregnancy is both safe and nutritious.
It's almost like having your own personal pregnancy dietitian in your back pocket that's going to not only tell you, is it safe to eat this? How much of that should I have? Yada, yada, yada. But give you actual meal plans so you know how to put it all together onto your plate today. And the meal plans are trimester specific, meaning, some women are kind of nauseous in their first trimester and maybe they need specific foods to help combat that. Prenatal Nutrition Library has got you covered. Or the fact that your baby's brain is growing rapidly in your third trimester and you need your nutrition to support that. Prenatal Nutrition Library meal plans has got you covered there too.
This is evidence-based information. Registered dietitians are in this app weekly answering members' questions. There's an exclusive podcast within the app that's run by Ryan, who is the prenatal dietitian that founded this entire thing. It's a wealth of knowledge and resources and will take you far beyond that one-page handout your doctor handed you that actually probably has out-of-date information about eating in pregnancy.
So head on over to the Prenatal Nutrition Library as soon as you get your big fat positive. Well, okay, first message me and Caitlin so we can do a happy dance with you. Then head over to the Prenatal Nutrition Library to get clear strategies to meet your nutrient needs, as well as to take the stress out of confirming what's safe and most optimal for you and your baby while you're pregnant. Use code FFF20 for 20% off.
The concept of celebrating food, I'm very much I'm interested by it because, again, we're a social species. And when I looked into it, we tend to celebrate different things over time. So, in the last, 20, 30 years, if we tend to celebrate food that's not nutritious to us.
Yeah.
And before it wasn't like that. So, again, I think this reimagining our relationship with food, what we eat, why we eat it, and it just because it's good and nutritious and wholesome, it doesn't mean it's bad. And you can, in a lot of other cultures, still maintain that. And so, because when we go out to eat, what do we eat? A lot of times, it's not necessarily things that are, or when we celebrate, we have big feasts. A lot of things are not wholesome and nutritious. Yeah,
it's always cake is like the penultimate celebration food in America.
And then if you go to other cultures, you have a big feast. What is it? A lot of that is, lean protein. It's fish, it's Mediterranean type style. Even in Japan, it's protein, it's fish, some rice. And so it's a little bit different. I think, and we weren't like this in the past either. Like all of our meals used to be, reasonable. And then I think in piecemeal fashion over time, what we wanted to eat, what we consider celebratory food or what we crave, kind of evolved to be these like very processed, sugary or unhealthy things, and then it became staples of our diet versus just things that we consumed rarely. And so I think that's a lot of reason why we have this issue.
It's very true. And when things that used to be celebration foods become cheap and available for everyday life, you find that when you're feeling run down, feeling low, feeling like you need kind of a pick-me-up in life, it's so easy to reach for the $3 carton of ice cream, which used to be only on birthdays when you were growing up. And now you can have this every day because it's cheap and it's accessible. And it's a way to get that like dopamine hit without using cocaine or alcohol or something that is immediately damaging.
Mm-hmm. And it's interesting, but have you in the recent past looked up the ingredients in any ice cream? It's not just milk, sugar, and what else is supposed to be, and cream.
Mm-hmm.
It's all kinds of stuff that I've never even heard of. And the question is, like, why is all that stuff in there?
Well, this was on my licensing exam.
Yeah.
Caitlin and I had to learn all about this in order to be called dietitians. But in long and short, it's thickeners, it's binders, it's stabilizing agents. It's made to keep a consistent product throughout the production line. It's made to keep it shelf stable, to avoid, frostbite and all these kinds of things, and to be able to use cheaper ingredients and still have it taste like ice cream. So if you look at the quality ice creams in the grocery store, they're far more expensive. So like a plain vanilla bean Haagen-Dazs, let's say, you flip that over, you look at the ingredients: cream, egg yolk, sugar, vanilla bean, and that's it. Maybe milk. That's really the only ingredients in there. And that's a far more expensive product, and it's labeled as ultra premium ice cream, versus if you get like the Thrifty brand or something that's much cheaper, like those little cups with the wooden spatula that you get in elementary school. That's where you've got locust bean gum, carrageenan, cornstarch, non-fat milk powder, basically cheaper ingredients that have emulsifiers and thickeners and stuff to make it more palatable and to taste like the real thing. And therein lies part of the issue why people are driven to eat, because these are just nutritionally replete ingredients that are not nourishing you at all, while giving your brain that, ooh, baby, that's good kind of feeling. So your body is saying, feed me, I need actual nutrition. And your brain is saying, hit me again, that was so good. And it ends up being this perfect storm where you want to buy more and eat more. And this is where a product like Wegovy, Trizepatide, Ozempic can kind of turn off the brain saying eat more. Meanwhile, your body still needs nutrition. So it does sort of disconnect those two things. And yeah, and like you said, this washout period for women that are trying to get pregnant, you don't want to be on this medication when you become pregnant. Is that right?
Correct. That is the recommendation that's currently in place. And so the reason for that is just we do not have adequate data demonstrating that it's non-teratogenic, safe in pregnancy. There has been some, uh, I don't want to say a lot, but there's been some use in women who are diabetic with really difficult to control diabetes, and they've been used, from what I understand, fairly safely without any side effects, with decent diabetes control. But it is, it's a different class of patients who are actually diabetic,
Because we do
and
have very solid data that type 1 diabetes, absolutely out of control with extreme lows and extreme highs, is very dangerous for a developing baby. We do know
yes,
that.
you're absolutely
And
right.
so
Yeah.
then a medication that ameliorates the thing that we know is bad, that does
hmm
something that maybe we don't know whether or not it's bad, the
hmm
juice can be worth the squeeze in those situations. And listener, I want to reiterate, Dr. Gary is not talking about gestational diabetes.
hmm
He's not talking about uh, when your blood sugars are, a little too high, and so your doctor wants you on a carb controlled diet and testing your sugars. That's not what we're talking about. We're talking about mothers
Yeah.
who have diabetes that is uncontrolled. Maybe they weren't even trying to conceive. They became pregnant, and now here
hmm
we are. What are we going to do? We have to do something. We can't just let these people perish. So we have to do something to help them. It's very different than, I'm trying to conceive. I've tried the blood sugar control thing. It doesn't really work for me. And so I want to use this medication because it seems so much easier. We're very different stories.
Yeah, it's a much different group of patients, um, and the amount of use is very, very limited at this point as well.
All right. Well, I think that we kind of are putting the cap on our trizepatide, our GLP agonist conversation here. Let's switch gears and talk about something that I know our listeners are wondering about, because I've heard a lot of questions about it. And that is this newfangled uterus test, where doctors can now apparently test for and confirm or deny endometriosis without surgery. They can just do this test and see some sort of protein or something. This is the cutting edge of endometriosis diagnosis, and I want to hear it straight from the horse's mouth. Dr. Gary, tell us about this testing.
So I think you're asking me about the Reproductive test.
That's the
So it's a
one.
Yeah, so it's a test that is an endometrial biopsy, which we touched on at the beginning of the podcast. So it is somewhat invasive, but the vast majority of women who have this biopsy, the biggest side effect would be like severe period cramping at worst, and typically managed with over-the-counter pain medications. Um, and we sent it to the laboratory, and the person looking under a microscope and then doing the genetic analysis on the sample can tell us what is the likelihood of the presence of endometriosis. So if specific proteins are present, there's a much higher likelihood that endometriosis is present. And if those specific findings are absent, there's a much lower likelihood that endometriosis is present. So it's not a absolute certainty that
Yeah.
it is a presence or absence, but it helps with potentially identifying it as a cause of infertility or some embryos who don't implant, or if there's symptoms that are concerning for endometriosis that somebody doesn't want to or opts out of having surgery. So it's a fairly useful test, and it helps in specific population groups get additional information to provide for a diagnosis if a diagnosis hasn't been made, for example, in women with undiagnosed or unexplained infertility. I never like to use unexplained because it should always theoretically be explained, and so I use more undiagnosed in our practice. And so if endometriosis is more likely based on the findings of this test, then we can offer treatment, whether it's medical treatment or surgical treatment. And head to head, they tend to be the same. To be honest, most people opt for medical treatment versus surgical treatment because a lot of women don't want to have surgery and they may not necessarily need surgery to improve their outcomes. And so different practices or different physicians may use this test in different ways. Primarily, it's been marketed or advertised to women who are undergoing IVF. And for example, if they undergo an embryo transfer and the embryo is optimal, it's euploid, the conditions were great, and the embryo doesn't implant, that would be potentially the next step to see if there's underlying endometriosis for that particular individual who had a suboptimal outcome after an embryo transfer. It's interesting because up until 2006, 2007, 8, anyone with undiagnosed endometriosis ended up having a laparoscopy because part of the evaluation was looking for endometriosis. And then we stopped doing that, and now we have a much less invasive test for endometriosis. So I certainly like this better, but I think an evaluation for endometriosis should be part of anyone who's undergoing fertility testing, especially who's been diagnosed with unexplained
From
endometriosis.
your lips to God's ears, Dr. Gary. Every day of my life am I fighting this battle that I have patients that they have never been evaluated for endometriosis. They have never even been evaluated for endometritis, like chronic inflammation, infection in the uterus, or even scar tissue in the uterus. And they've had embryo transfer after embryo transfer, and nothing has happened for them, and they still haven't had this testing. And it's just absolutely a horrible way to practice. These embryos are not, it's not gumballs that were just, pop another one in the machine if that one didn't go. This is precious human life. And doctors are like, oh, well, we'll do another retrieval. What? It's not just another retrieval. That's extreme. And I love what you said right there, that a thorough endometriosis evaluation is necessary and treatment is necessary for these patients with endometriosis, because if you don't treat properly. First of all, proper treatment with endometriosis can often result in you don't even need IVF anymore.
Hmm. Hmm.
Secondly, if you don't properly treat endometriosis and go through IVF, in my experience, especially if the endometriosis is on or near the ovary, we have such poor outcomes for the retrieval. And then if it's other places, poor outcomes for the transfer.
Yeah, well, there's definitely risks and benefits of endometriosis treatment, and depends on how extensive it is. Surgical treatment can potentially, decrease for the reproductive capacity of the patient. So, for example, if somebody has, extensive surgery and we do a lot of resection on the ovary, that can potentially even drop the
Mm-hmm.
ovarian reserve and potentially decrease um, response to any kind of future treatment, whether it's ovarian stimulation, ability to get pregnant spontaneously, or IVF. So there, a lot of things in this space is a trade-off. But I agree with you. Under detecting and treating endometriosis properly, and what we mean by properly is going to vary for every individual patient, tends to optimize outcomes either with spontaneous pregnancy or with any kind of fertility intervention. Before we had IVF and before we had laparoscopy, a lot of women underwent open surgery, and we would try to
Mm-hmm.
resect as much endometriosis as we could and then allow them to get pregnant. Then, as we developed much better laparoscopic techniques and ability to what we call cytoreduce, or minimize as much disease as possible with lasers and different electrosurgical instruments, that is going to improve the probability of successful conception without any intervention. But unfortunately, a lot of times endometriosis, the inflammation is so severe that it causes tubal disease, and the tubes become inefficient at transporting sperm and eggs toward each other and transporting fertilized eggs or embryos into the uterus. And so we don't necessarily want to do surgery and then not intervene after a certain amount of time, or treat somebody with medicine and not intervene after a certain amount of time, because the longer we don't do anything without a spontaneous conception, there's a potential that our interventions become less effective with time, as well as age and decreases in ovarian reserve um, become more impactful on the natural fertility and or the ability to respond to fertility treatments. So, and then in some women, it depends on the disease or how the disease is impacted, the anatomy. IVF may be the right answer, it may not be the right answer. So everyone's going to be a little bit different. But endometriosis tends to be much more prevalent in women who have not gotten pregnant or have fertility issues. So it's certainly important to identify, diagnose, and then appropriately treat. And so let's use the example of endometriosis, and then maybe potentially we can transition into how it um, can impact our message when it comes to improving the lifestyle. And so, if um, there's going to be a significant increase in the diagnosis, is that help somebody with regards to, if you have that information, can you act on it? And I think it does. It does give somebody a peace of mind versus just not having an answer. And so, if we look at somebody, for example, who's really, really trying to lose weight, I think the message that in terms of what resonates and what's beneficial, what we found effective is that what we communicate is that the benefit that somebody gets in terms of their reproductive ability, in terms of obviously if there's not any other anatomical things that we're dealing with, but the reduction in uh, the miscarriage rate, the reduction in the pregnancy complications rate, the reduction in complications during delivery, and the benefits to long-term health by getting to a healthier BMI, optimizing your nutrition. That statistic, that benefit is much better than anything we can do in medicine, in terms of giving you medication, putting you through certain treatments with decreasing your ability to continue a pregnancy. So getting to optimal health or improving your health, you don't even have to get to optimal health, but getting to a point where BMI is healthy, the metabolic biomarkers are normalized, blood pressure is better, you're off of blood pressure medications. Um, that benefit, statistically speaking, in terms of improving outcomes, is much better than anything that we can do medically in terms of, you know, putting you on a drug or taking you through a treatment. And it's better if, I mean, better outcomes if you're not alone. And I don't think you should be alone in this journey either. Like, for example, you ladies are a significant resource to so many people out there who are on this journey. You know, we do as what we can as well, but I think it's much easier to be in a group or have resources that assist you with this journey. You certainly can do it alone, but it's much easier, I think, if you're not.
Yeah.
Hey guys, we're taking a break from our episode, and I want to talk about something that's super confusing. When you head down the supplement aisle and you're looking for a prenatal, and on the prenatal bottle itself, it says, do not take if you're trying to conceive, pregnant, or breastfeeding. Like, what the heck?
It says talk to your doctor if you are pregnant, could be pregnant, breastfeeding, postpartum, whatever. And every supplement has this. You go down the supplement aisle, you go shopping on whatever supplement website, and there's a disclaimer on every bottle of every single thing, which means that everything that you've been taking your whole life long is now a big question mark about whether or not you are potentially harming yourself by taking something where you're trying to be healthy. So that is why we partnered with Needed. Needed is a perinatal nutrition supplement brand that has a wide array of products specifically designed for women who are pregnant, trying to become pregnant, breastfeeding, or postpartum. So it's not just that these products like can work if you're in that situation, or oh, it's probably okay if you take it while you're trying to conceive. No. These products are researched, they are formulated, and they are put together specifically for women who are trying to conceive, pregnant, breastfeeding, and postpartum.
This answers so many questions. I always get asked, like, what can I take? It's cold and flu season. What's safe? Needed has an immune support. That's safe whether you're trying to conceive, pregnant. It's even safe for your little ones.
And it's not just immune support. They've got collagen, they've got hydration support, they have digestive support, they have prenatal multi. They even made a line for dudes.
Needed is somebody we're really proud to be partnering with. So head over to their website and use code FFF20 for 20% off your order.
Part of the tenets of what we do, or probably the main one, is that we want to treat everyone like we want ourselves treated and we want our wives treated. And so we can see, for the most part, if somebody tries, it needs to be seen the same day, we certainly can do that. And just to give you an example, like my son was just not feeling well and he had a stomach ache. And we called this clinic, and the first available appointment was in 4 weeks through telehealth and in person in like 6 weeks. And this is somebody with abdominal pain. It's not something that can wait a month, for example.
Mm-hmm.
And so we never ever want anybody to be in that situation that is getting care as, you know, as important and as intimate and as personal as reproductive care. And so it's an emergency to everyone that's you know, trying to get pregnant. And I know that the messaging may not be that it's emergency because people say you have to wait X amount of time depending on your age. But I'm sure it feels like an emergency when someone's trying and they want to be pregnant yesterday.
Well, especially when we're
And
not
so,
just talking about somebody that's like, oh, I just want to be pregnant. A lot of times we're
mhm,
talking about people that are having symptoms. They are having pain. They are having abnormal bleeding. They are
mhm,
not ovulating. I mean, there's a things going on that isn't just, hey, we tried for a year and nothing happened. Because if you're
mhm,
going to do that, okay, well, 6 weeks from now, like whatever, I'll just schedule that. It's not that big of a deal. It's
mhm,
that there's a clear and present pathology that no one has taken the time
right.
or been able to look at. And then the very, very worst is when you do wait that 8 weeks and then you go into this endometriosis specialist or fertility specialist or whatever, and they totally blow you off.
Mhm.
That's the
And so
worst.
that, yeah, it is absolutely the worst. And you brought a very, very important point. So those recommendations that you wait 6 months, a year, again, depending, stratified by age, are only applicable to people who have no risk factors for any kind of reproductive
Exactly.
dysfunction. So if a male partner's been on testosterone, you do not wait. You have to go and get care. If you have irregular periods, you do not wait. You go in and you get seen. If you have really painful periods, that is the number one sign of endometriosis. It's absolutely abnormal for your periods to be incapacitating. So you do not wait. You go get care. Those recommendations are only applicable to somebody who has like no risk factors for anything that's going to
You've
prevent or
heard it
delay
here
pregnancy.
first. A doctor saying your period shouldn't be incapacitating. I cannot tell you, hundreds of women I worked with have been absolutely dismissed. Oh, it's just a part of being a woman. Like, why don't you just, take an Advil and drink a glass of wine and shut the hell up? Yeah, have you tried taking a bath? Like, just crap like that, and being totally dismissed for incapacitating pain where they cannot go to school, they cannot go to work, they're having fevers, they're vomiting, they're losing consciousness during their period because of the pain, and they're being, maybe given a prescription for some 800 milligram ibuprofen, and that's about it. Birth control.
None
Yeah,
of
that's
that
the
is
other one.
none of that is normal, right? None of that is normal, and you should seek medical care for any of those symptoms, and definitely if you have a combination of any of those. The controversial thing right now is whether or not do we universally apply pre-implantation genetic testing to embryos, for example, when we do IVF, and there are very, very entrenched camps on both sides of the issue, and we always have very spirited discussions about this topic when we meet, and the different camps feel strongly about the utility or the ineffectiveness of genetic testing on the embryos. So I think maybe in the next couple of years, we may get some studies that will settle this debate, and whether or not that's going to be one way or another is difficult to tell at this point.
Oh, I
But
can tell you
that's
which way it's going to go.
yeah. Well,
Which way
um,
which way is more lucrative? Definitely the testing
so
route, right? Well, we'll,
but
we'll all
it
be
is getting
shocked in a few years when that's the way
yeah,
it goes.
it is getting cheaper as the technology improves. But yes, it's definitely an additional cost to the patient by doing the genetic testing.
And you can
And
really play
it,
on her fears, and you can really say, oh, well, this won't happen and that won't happen, and all these things will be fine if we do it.
right. Yeah, if somebody, for example, really wants to pick the sex of the baby, I mean, it's definitely something that would provide you an answer. If somebody is coming for with multiple miscarriages, and the reason why they're miscarrying, for example, is chromosomal abnormalities,
Mm-hmm.
and it can discriminate between the embryos that we should transfer first versus not transfer. So there are specific cases where it's definitely useful. But I think in my opinion, is that as global application and the long-term prognosis, it doesn't necessarily change, but it can save costs depending on how many transfers and how much PGT costs. So, Ian, it's a controversial topic, and there are supporters and there are people who object to it as a universal application. But that's kind of the big topic in the fertility space for the last few years.
Hmm. Well, thanks for spilling the tea on the hot
hmm
goss in the reproductive endocrinology world.
Yeah, absolutely, absolutely. And then I think the newer thing that is going to emerge is going to be direct to consumer um, testing as the technology improves
It's
and
going to need
women,
to improve quite a bit before I start
yeah,
recommending it.
and I
I've just
agree with
seen too
you.
many discrepancies. Hey, it's me again, Sophia Pavia, registered dietitian nutritionist specializing in women's health, fertility, and optimal progesterone production. And I'm interrupting an episode of my own podcast to tell you about my online course called Ovulation Unlocked. So if you've been listening to our podcast episodes, you've probably heard a lot of things about basal body temperature, cervical mucus, cervical position, and tracking your fertility. Well, I have designed a 90-minute self-paced online course, which I titled Ovulation Unlocked, that puts all of that together and teaches you how to be the expert on your own fertility from home. This course is designed to put you in the driver's seat of your own fertility, not only so you can know what's going on with your body on any given day, but so that if you need medical help, you can show up to the appointment informed and ready to communicate. Too frequently, us women show up to our doctor's appointments and just say something like, I want to have a baby. And the doctor looks at you and says, good for you. Stop using birth control, start taking a prenatal, come back in a year if you're not pregnant. And that's all we get. However, Ovulation Unlocked puts you in the driver's seat, puts you in control of your fertility to where if you need help, you can show up to that appointment informed and ready to communicate your needs. So if you want to become the expert on your own body and your own fertility, head on over to my Instagram bio and tap the Ovulation Unlocked link. I love that you're just a fangirl, Dr. Gary, for a minute here. There's so little, you're just a very confident man. There doesn't seem to be like an arrogance there to exactly that needs everyone in his practice to do it exactly his way. And if somebody you just have like the heart of a learner, I guess, that like you want to do what's best and know what's best and practice the best way. And if that's not your exact way in your clinic right now, who cares? You're just ready to help. And I think that's just so admirable about you. I love having you on the show and hearing the way that you talk about these things because you just have such a unique heart as a doctor.
Well, I appreciate that. That's by far the best part of our job.
I so agree.
When we see babies, whether it's pictures or people bring them to the office, that's kind of what drew me into it when I was a resident, and then you would follow around the reproductive endocrinologist, and then people would bring their babies and
a reproductive endocrinologist that likes babies. How astonishing. I can't tell you, that's actually kind of rare. That's wonderful to hear.
So yes, it's an honor for them to come to the office or send you pictures or Christmas cards with babies that you've helped conceive. I mean, it's very difficult to put into words like that. It's like pride and professional pride, and it's very, 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 it's reassuring, and it's supportive of everything that we do. How do I phrase this? So it may not be the journey that everybody wants a plan for, but sometimes it takes a lot of bends and different forks in the road. But most of the time we can get to a point where it's a satisfactory result.
It's like 6 a.m. for Dr. Gary right now, so we should all be pretty impressed that he's this articulate this early, and especially without his coffee.
We try. I'm about to go get a big cup right about now. I look forward to joining you ladies on a regular basis. It's been an absolute pleasure speaking with you over the last hour and a half, and then in the prior episodes that we've done. It's very, very enjoyable. And to be honest, it creates questions that I go back and I
can tell.
Research.
I can tell you do that. And it is so great.
Because we should never stop learning, right? We should never stop learning. We're in this business to help people, and information comes out all the time, and we get very, very busy, and we have to continue to improve ourselves so we can help our patients every single day. And I firmly, firmly believe that. So I look forward to our ongoing
That's our yeah girl, is we'll have a communal yeah girl, and it's going to be the Ask a Doc brought to you by FertilityCloud, where Caitlin and I will talk about a topic, and we'll be like, well, actually, I don't know. Dr. Gary, let's hear what you have to say about ovarian hyperstimulation syndrome, or, whatever it is. And then he'll pop in and answer your questions from a doctor's perspective. So if you've ever wished you could just talk to your doctor and not have to go through like the phone tree and then the front desk and then leave a message and they don't really write it properly and then the response is kind of weird and we're bypassing it all and you've now got a doc in your pocket and his name is Dr. Gary.
All right, ladies. Well, thank you so much. I
Thank
love
you
the
so
Jaeger.
much. Good morning and have a good day.
Yeah, you guys take care and stay out of trouble today, okay?
All righty. We'll try.
Bye.
All right. So that's another episode of Food, Freedom, and Fertility. If you liked it, if you loved it, if you have anything to say about it, we want to hear what you have to say. So leave a comment, write a review, subscribe, rate us. It helps other people find us so that this information can get to the people who need it most. So thanks for listening and we'll see you next time.
Hey, it's Sophia. If you love the show and want to continue your health and fertility journey using our resources, head on over to foodfreedomfertility.com for show notes, links to products and services, information about our guests, and our newsletter. Again, that's foodfreedomfertility.com. Thanks for listening.